Usually when we talk about a medical diagnosis, there's like this expectation of total precision.
Right, yeah, like it's engineering or something.
Exactly. You break your arm, they do an x-ray, and you see that jagged white line. And the doctor just points and says, there it is.
Yeah, broken or not broken. Very binary.
It's binary, and frankly, I mean, it's comforting. But then you step into the world of women's pelvic health, and suddenly that x-ray machine is just useless.
Oh, completely. We rely so heavily on that visibility in medicine. The whole system is basically built around categorizing things we can clearly measure and see.
Right. And today, we are wading directly into some incredibly murky diagnostic waters. We're doing a deep dive into a highly searched, but, rarely discussed medical question.
And it's a big one.
It is. Can a surgical menopause actually worsen the feeling of vaginal looseness?
That is a question that surfaces constantly in clinical settings. And it's usually accompanied by a lot of distress, Yet it's surrounded by this astonishing wall of silence in public discourse.
Yeah, it's crazy. So to break down that wall for you today, we have a really comprehensive stack of sources.
We do.
We're pulling from clinical guidelines from the National Institute for Health and Care Excellence. That's nice CEE over in the UK. Plus consensus statements from the British Menopause Society.
And we've got some really grounded clinical data from specialized women's health clinics, too.
Right. Because our mission today is to cut through the stigma and, honestly, the marketing jargon to understand the actual anatomy of what gets labeled as vaginal laxity.
Exactly. We really need to look at what's genuinely happening to the tissue, especially how an abrupt surgical menopause acts as an accelerant to all of this.
And, of course, we'll get into what evidence-based solutions actually work. But first, let's establish what we actually mean when we use the term laxity. Because it's not some straightforward clinical diagnosis, right? You can't just draw blood and test your laxity level.
No, you can't. And that's really the crux of the diagnostic challenge here. Vaginal laxity, or, looseness, is a subjective symptom.
Subjective meaning it's based on feeling.
Yes. It is the patient's own internal sensation of a loss of resistance. In the medical literature, it frequently just gets lumped in with general pelvic floor dysfunction.
Which is frustrating.
Very.
Yeah.
Because for the person actually experiencing it, it is a very distinct, specific feeling. A feeling that the fundamental support structure down there has changed.
Okay, so speaking of support structures, one of our sources from the University College London hospitals uses this analogy that really helped me visualize it. They describe the pelvic floor as a strong hammock.
That's a classic analogy, yeah.
Right, so it's this network of interrelated muscles, fibrous tissues, and ligaments at the base of the pelvis. And its job is to hold up the heavy organs like the bladder, the uterus, the bowel.
Right.
So if that muscular hammock weakens, the organs bear down. Things feel heavy or literally loose. But, if we follow that logic, a feeling of looseness seems like a purely mechanical problem.
How so?
Like a hammock that's just been stretched out by bearing too much weight over time, or, specifically from the trauma of childbirth. It's not just a muscle issue.
Well, that is the assumption most people start with. Honestly, even many practitioners start there. But while childbirth is undeniably a common trigger for stretching those muscles, attributing laxity entirely to the muscular hammock misses half the anatomy.
Wait, really? Misses half of it?
Yeah. The sensation of looseness is deeply, deeply tied to the actual tissue of the vaginal wall itself. The wall isn't just a single sheet of muscle. It actually has 3 distinct layers.
All right, I saw this in the notes. You have the inner lining, the muscle, and the connective tissue, right?
Precisely. So the outermost layer is the adventitia, which connects it to the surrounding organs. Then you have the muscularis, the muscle layer.
Okay.
But the innermost layer, the mucosa, is where things get really dynamic. In a healthy premenopausal state, that mucosal lining relies heavily on the hormone estrogen.
To do what?
To maintain its thickness, its blood flow, and its rugae.
Ah, the rugae. Those are the folds that look a bit like the pleats of an accordion, right?
That is a perfect way to visualize it. Yes, those rugae folds allow the vaginal canal to stretch expansively, like during intercourse or childbirth, and then, crucially, to recoil back to its original shape.
Oh, wow. So they act like springs.
Exactly. And estrogen is the architect maintaining those pleats. When estrogen levels drop, that architectural scaffolding is basically dismantled.
So the accordion loses its pleats.
It does.
The tissue itself loses its ability to spring back. Which means the feeling of looseness isn't just the hammock drooping. The actual fabric of the hammock is degrading.
Yes. The physical volume and elasticity of the tissue are severely compromised. It's a profound structural change, not just a muscular one.
Wow. Okay, so if estrogen is the architect holding this whole structure together, what happens when someone undergoes a surgical menopause? Because, I mean, there has to be a massive biological difference between just natural aging and waking up from surgery without your ovaries.
The difference in the biological timeline is staggering. I mean, natural menopause is a transition. It typically happens around age 51, and the ovaries slowly wind down their hormone production over a period of years.
Right, so the body has time to adjust.
Exactly. But surgical menopause, which usually results from a bilateral oophorectomy, so the removal of both ovaries, is an immediate overnight event.
And women might undergo that for several reasons, right? Like, it's often part of a hysterectomy to treat severe endometriosis. Or it's done preventatively for women with BRCA gene mutations who have a high risk of ovarian or breast cancer.
Right, and whatever the underlying reason, the endocrine result is exactly the same. The very moment those ovaries are removed, ovarian hormone production ceases completely.
Overnight.
Overnight, estrogen and progesterone drop to near zero immediately. And furthermore, because the ovaries produce roughly half of the body's testosterone, you see a 50% drop in testosterone overnight, too.
Gosh. So for the vaginal tissues that are just relying on those hormones to maintain their structure, that overnight drop has to be a massive biological shock.
It's an earthquake.
Well, the sources from Right Decisions and the British Menopause Society detail the cellular mechanics of what estrogen actually does for this tissue. And the complexity is just remarkable.
It really is. The vaginal microbiome and tissue architecture operate in this highly calibrated, continuous loop. When estrogen is abundant, it drives a very rapid cellular turnover in the superficial cells of the mucosal lining.
Right. I wanted to ask about this. How rapid are we talking?
Those cells shed and replace themselves approximately every 4 hours.
Every 4 hours. That is wild. The sheer caloric and biological energy required to maintain that turnover rate is incredible.
It is an incredibly active environment. And as those cells shed, they release glycogen. That glycogen serves as the primary food source for the beneficial bacteria in the vagina, the lactobacilli.
Okay, so the cells feed the bacteria.
Right. The lactobacilli consume the glycogen and produce lactic acid as a byproduct.
And that lactic acid is what keeps the vaginal environment at a low acidic pH, right?
Sure.
Usually under 4.5 or something, which makes it hostile to harmful bacteria and yeast.
Exactly. It's a brilliant self-sustaining defense mechanism. The estrogen fuels the cell turnover, the cells feed the good bacteria, and the bacteria maintain the acidic shield that protects everything from infection and inflammation.
So then, surgical menopause happens. And that entire ecosystem just crashes overnight.
Completely crashes.
Because without estrogen, the engine driving that 4-hour turnover loses its fuel, the cells start shedding, the glycogen disappears, the lactobacilli starve, and the pH rises, leaving everything totally vulnerable.
Yes.
But it's beyond just the microbiome, right? This
Yeah.
is my big aha moment reading the sources. The structural cells themselves essentially shut down. The sources point out that fibroblasts, the cells responsible for making collagen and elastin, they literally go dormant.
Yes, they do. They transition into an inactive state, becoming what we call fibrocytes. And this is where the structural collapse truly begins. Without active fibroblasts constantly renewing that collagen matrix, the existing collagen fibers begin to hyalinize.
Hyalinize, meaning they fuse together into stiff, glassy bundles instead of staying separate and springy.
They fuse, and simultaneously the elastin fibers fragment and break down. So because the tissue is no longer undergoing that robust 4-hour turnover, it physically thins out.
So the rugae disappear.
Exactly. Those accordion pleats we discussed, they just flatten out.
It's like taking the springs out of a mattress and then stripping away the top layers of padding.
Yeah.
The fabric left behind just sags and loses all its structure.
That is exactly the mechanical reality of it. The sudden atrophy means the tissue just can't recoil anymore. It loses its elasticity and its volume.
Right.
So to answer the core question of this deep dive, yes, surgical menopause absolutely worsens the feeling of looseness. The sudden deprivation of estrogen creates a profound, rapid sensation of laxity, alongside severe dryness and a distinct lack of friction.
Which really brings us to the broader clinical picture. Because of this localized structural collapse, it isn't happening in a vacuum. It falls under a broader umbrella term that's discussed heavily in the clinical sources, which is GSM, genitourinary syndrome of menopause.
Yes. The medical community actually shifted to using the term GSM back in 2014. We moved away from older terms like vulvovaginal atrophy.
Why the change?
Because atrophy merely describes the microscopic appearance of the thin tissue. GSM is much more accurate. It captures the wide-ranging syndrome of symptoms that occur when multiple systems, the vagina, the vulva, the urethra, the bladder, they are all reacting to the loss of estrogen.
And the prevalence of this is just staggering. According to the data we pulled from the National Institutes of Health and the British Society of Sexual Medicine, about 70% of postmenopausal women experience symptoms of GSM.
70%. It is arguably one of the most common physical changes associated with menopause, whether it's natural or surgical.
But here's the crazy part. The data also shows that only 7% of those women actually receive treatment.
Yeah, that gap is heartbreaking.
A gap between 70% experiencing it and 7% getting help is a massive failure in communication and care. I mean, many people just assume these symptoms are an inevitable reality of getting older, that they just have to silently endure.
The stigma is deeply entrenched, and because the symptoms can be, well, embarrassing to discuss, patients often don't bring them up, and unfortunately, many physicians completely fail to ask.
One specific symptom highlighted in the Women's Health Clinic sources illustrates this stigma perfectly. It's the physical phenomenon of air trapping.
Right.
Colloquially, people use terms for this that carry a lot of shame like queefing, but medically it's just a very straightforward mechanical issue resulting from GSM. Can you explain the mechanics behind that?
Absolutely. It is a frequent complaint, and it really causes significant psychological distress. But if we just apply the anatomical changes we just discussed, the mechanics make complete sense. So you have a pelvic floor that might already be slightly compromised. Now, add the sudden loss of estrogen from surgical menopause, the vaginal canal loses its rugae.
The pleats are gone.
Right, meaning it is physically wider and the tissues are less elastic. They don't hug together to maintain a closed, collapsed space the way they previously did.
So the internal walls are basically just sitting slightly open.
Correct. So during any kind of movement that changes your intra-abdominal pressure, like going up from a chair, doing yoga, exercising, or during sexual intimacy, that wider, less resilient space naturally pulls air in.
Right.
And then when the body position shifts again, the trapped air is forced out. It is a direct physical manifestation of the laxity and tissue thinning. It's just basic physics. But because of the area of the body involved, people feel immense shame.
Exactly. Just understanding that it's just physics driven by cellular changes, I think, removes so much of that shame. But air trapping is just one facet of this. The impact of GSM fundamentally alters a person's relationship with intimacy and their own body.
It really does.
The sources use a highly descriptive phrase for the lack of lubrication that happens. They call it cactus dryness.
Oh, it's a very vivid description of a very painful reality. Because the mucosal lining is so incredibly thin now, and it lacks its protective acidic barrier and natural lubrication, it becomes extremely fragile.
Yeah.
Friction during intercourse isn't merely uncomfortable. It physically causes micro tears in the tissue, which leads to bleeding and severe pain. Clinically, we call that dyspareunia.
And it extends far beyond sexual intimacy, too. The sources note that when the tissue is inflamed and paper-thin, simple daily activities become agonizing, like sitting at a desk for 8 hours or wearing tailored clothing or riding a bicycle. It can all cause constant irritation.
This is exactly why recognizing GSM is so critical. When it hurts to walk or sit, it impacts your mobility, your psychological well-being, your overall quality of life. I mean, it is not a cosmetic issue. It is a functional impairment.
So, if we know the cellular engine has stalled, and we know the profound functional impact, how do we fix it? Because when someone experiences this feeling of looseness and they go looking for solutions online, the most ubiquitous advice they'll find is to just do Kegel exercises.
Oh, yes.
The narrative is, like, if you feel loose, shouldn't you just do 1,000,000 Kegels to strengthen your pelvic floor?
Right. And this is a pervasive misconception that causes a lot of frustration for patients. Don't get me wrong, pelvic floor physical therapy, including Kegels, is highly valuable. It is crucial for strengthening the muscularis layer.
The hammock we talked about.
Right. Strengthening those muscles can help lift the pelvic organs and significantly improve issues like urinary incontinence.
But Kegels are working the muscle, not the mucosa.
Exactly. You can have the strongest, most well-conditioned pelvic floor muscles possible, but if your mucosal lining is deprived of estrogen, if it remains thin, dry, and lacking in collagen and elastin, you are still going to experience the symptoms of laxity, dryness, and pain.
Right, because muscle exercises can't generate estrogen.
They absolutely cannot. They cannot restart that 4-hour cellular turnover or rebuild the rugae.
So to fix an estrogen deficiency problem, you have to actually address the estrogen deficiency.
Bingo.
The British Menopause Society guidelines are very definitive on this, particularly for women who experience surgical menopause before the age of 45. They strongly recommend systemic hormone replacement therapy, or HRT.
Systemic HRT, so that's delivered via patches, gels, or pills, is vital for this demographic. And it's important to clarify that systemic HRT isn't prescribed solely to treat vaginal laxity.
Oh no, it's for the whole body.
Right. When a woman under 45 loses her ovaries, her risk of cardiovascular disease essentially doubles without estrogen replacement. She also faces a dramatically accelerated loss of bone density, which leads to early onset osteoporosis. And there are documented risks regarding cognitive health, too.
Wow. So systemic HRT is really a protective measure for the heart, the skeleton, and the brain.
Exactly.
But when it comes to targeting the specific localized symptoms of GSM, the dryness, the tissue thinning, the localized laxity, the clinical consensus heavily favors local vaginal estrogen.
Yes. Local estrogen therapy, usually in the form of creams, pessaries, or vaginal rings, is widely considered the gold standard treatment for GSM.
And the pharmacology here is just fascinating.
It is. You are applying a very low dose of estrogen directly to the affected tissue. It operates locally, meaning the systemic absorption into your bloodstream is minimal, which is really reassuring for patients who may have contraindications or concerns about taking systemic hormones.
Right. And because it's applied directly to the site, it goes straight to work on those dormant fibroblasts we were talking about.
Yes. It literally signals the fibroblasts to wake up and resume production. It restarts the collagen synthesis, reactivates that rapid cellular turnover, and restores the glycogen production that feeds the lactobacilli.
The whole system turns back on.
The blood flow increases, the tissue physically thickens, the rugae begin to reform, and the pH normalizes. The localized biological engine is essentially turned back on.
And the clinical response to local estrogen is documented as being both rapid and highly effective, which is great.
Hooray.
But, of course, estrogen isn't the only solution marketed to women out there. If someone searches for vaginal tightening online, they will inevitably be flooded with advertisements for non-surgical tightening clinics offering laser treatments.
They are everywhere.
Yeah, and it sounds incredibly advanced. But how do these devices actually interact with this fragile tissue?
Well, the devices in question are typically fractional CO2 or erbium lasers. The National Institute for Health and Care Excellence, or IGZIA, which is the body that provides national guidance in the UK, they've reviewed these technologies extensively.
And what did they find?
The fundamental mechanism of action for these lasers involves causing controlled thermal injury to the vaginal wall.
Let me stop you there. Thermal injury. So they're using directed heat to create microscopic burns in the tissue.
That is the mechanism, yes. The objective is to leverage the body's natural wound healing cascade. The thermal injury is meant to trigger inflammation, which signals the body to rush new collagen to the damaged area. It's a process called neocollagenesis.
Okay, see.
The theory is that the resulting swelling and new collagen will restructure the tissue, increasing both elasticity and moisture.
And to be fair to the data in the NIOC overview, there are studies demonstrating some short-term improvement. Some patients do report better vaginal health index scores and temporary relief from the looseness.
Yes, that data exists.
But the safety data within these sources presents a much more complicated picture. The FDA, alongside various clinical reports, has documented severe adverse events that shockingly aren't typically highlighted in clinic marketing materials.
Right. We have to evaluate the risk profile very carefully here. While neocollagenesis sounds ideal, the long-term efficacy and safety of these devices for GSM remain insufficiently proven.
Which is why it's not a standard treatment, right?
Exactly. It's not currently an approved treatment for this condition on the National Health Service in the UK. The potential for the healing process to go wrong is significant, particularly in tissue that is already estrogen deprived and super fragile.
The clinical case studies of these adverse events are harrowing. We're looking at reports of patients who underwent these laser procedures and developed persistent, progressively worsening pelvic pain. There were even documented cases of severe levator antispasms.
And the levator ani is a crucial part of the pelvic floor muscle group. When it goes into spasm, it is essentially a constant, agonizing cramp deep within the pelvis. It can make sitting, walking, or sexual function nearly impossible.
God. In one specific case study, a patient's body reacted to the thermal injury not by creating that nice elastic collagen, but by forming dense scar tissue. She developed a crescent-shaped fibrous band mid-vagina that created a partial anatomical obstruction.
That is a severe complication.
And there's another report that detailed a woman who resumed intercourse a few weeks post-laser therapy, and she suffered severe vaginal lacerations. And as those lacerations healed, the resulting fibrotic scarring was so extensive that it physically shortened her vaginal canal to just 2.5 centimeters.
Oh, wow.
Yeah. The management for that complication required the use of dilators and heavy lubrication just to maintain basic function.
Those cases perfectly illustrate the physiological unpredictability of thermal injury. The body's emergency healing response often favors laying down dense, stiff scar tissue fibrosis rather than organized, stretchy collagen.
Right.
And this brings us to a fundamental principle emphasized in the Women's Health Clinic guidelines. Clinical diagnosis must always precede the application of a device.
You have to know exactly what is causing the symptom before you try to treat it.
Exactly. A sensation of looseness could be driven by estrogen deficiency, sure, but it could also be a subtle pelvic organ prolapse or an unhealed muscular avulsion from a previous childbirth.
The laser wouldn't even help those.
No. And if a practitioner applies a thermal laser without diagnosing the root anatomical cause, they risk exacerbating the issue or creating devastating new complications like the fibrosis you described. Furthermore, if a patient has an underlying connective tissue disorder, like Ehlers-Danlos syndrome, their collagen synthesis is already altered.
So adding a laser to that.
Subjecting that tissue to energy devices can yield highly unpredictable and dangerous results.
It really underscores why seeking out a specialized medical evaluation is so vital, rather than just relying on commercial clinic interventions as a first line of defense.
Absolutely.
But while navigating medical treatments like HRT or local estrogen, the sources also outline some practical, immediate adjustments that can mitigate the symptoms of laxity and dryness right now.
Yes, from a practical perspective, adjusting sexual positions can naturally compensate for the mechanical feeling of a wider vaginal canal.
Okay, how so?
The Women's Health Clinic notes that positions allowing for deeper, more direct contact or a tighter angle can enhance sensation and friction for both partners, which directly counteracts that feeling of looseness.
That makes sense. And the strategic use of high-quality topical products is critical here, too. The sources draw a really clear distinction between moisturizers and lubricants, which serve totally different purposes.
They do. Vaginal moisturizers are designed for regular, ongoing use. They are absorbed into the tissue to hydrate it over time, much like a daily face cream.
Okay.
Lubricants, on the other hand, sit on the surface of the tissue to temporarily reduce friction, specifically during intimacy. The British Menopause Society specifically highlights targeted products like Silk Intimate Lubricant or YesES Vaginal Moisturizer.
The key is avoiding those highly commercial synthetic products you often find in drugstores.
Right.
Like anything containing heavy perfumes, artificial dyes, or those warming and cooling chemicals. They will actively irritate and further damage mucosal tissue that is already compromised and paper thin.
Exactly. The environment is already missing its protective acidic barrier. Introducing synthetic irritants into that vulnerable ecosystem is just a recipe for severe inflammation and infection.
So when we synthesize all of this, the narrative around vaginal laxity shifts completely.
It really does.
It is not just in a person's head, and it is not purely a muscular issue resulting from a weak pelvic floor. It is a tangible architectural change in the tissue itself, a literal breakdown of collagen, a loss of the elastic rugae folds, and a complete shutdown of cellular turnover.
And we can conclusively say that surgical menopause acts as a dramatic accelerant to this process. By abruptly terminating the body's estrogen supply overnight, it halts the tissue's biological repair mechanisms, which leads to sudden, profound thinning, dryness, and the mechanical reality of looseness.
But the most vital piece of information from this deep dive is that it is highly treatable.
That is the ultimate takeaway. The symptoms of GSM, including laxity and dyspareunia, are biological processes with clear, evidence-based interventions. Whether the appropriate path involves systemic HRT to safeguard long-term cardiovascular and bone health, or localized vaginal estrogen to reactivate those dormant fibroblasts, or targeted pelvic floor physical therapy, there are effective clinical options. No one should accept these symptoms as an inevitable decline to be endured in silence.
You have the right to demand a proper, specific diagnosis and to pursue treatments that respect the complex biology of your body.
Knowledge equips you to ask the right questions. Speaking to a menopause specialist and advocating for evidence-based care can entirely restore your quality of life.
We started today by comparing diagnosis to an X-ray, looking for a simple broken line. But we've seen how an overnight drop in a single hormone completely rewires the physical structure of the pelvic floor, right down to the behavior of individual cells.
It's incredible.
It makes you wonder, if estrogen receptors are quietly maintaining the structural integrity of tissues we can't even see, what other microscopic architectures in your body are secretly relying on a hormonal valence you don't even know is there until it shifts?
It really highlights just how interconnected our endocrine and structural systems truly are.
Definitely something to ponder as you digest today's research. Thanks for joining us for this deep dive. Keep questioning the consensus, keep looking at the data, and we'll see you next time.